How can the maternal mortality rate in the US improve if we have counties that don't even have obstetrical services? You heard me, so let's talk about it. Hey, you guys. So, guess who's back? Yes, I am back, and I'm here to talk about a very important topic. I know that many of us have heard about the maternal mortality issue, but really haven't had the opportunity to understand why the issue even exists. I know we've talked about racism, and that is clearly a underlying and major factor. But there are other things going on in women's health that we should probably all be aware of so that we can have better understanding of why we have such a high maternal mortality rate. Did you know that there was a program that was funded by the government, the federal government, called Healthy Start? So Healthy Start was started in 1991. And if you're a woman who was of childbearing age in 1991, you're probably wondering, why didn't I hear about this program or know that it even existed? We're going to talk about it. So, this program was started really with an effort to improve maternal and child care outcomes. In fact, this program is still around, by the way. And in fact, in 2021, they actually funded over $115 million to 101 community organizations or efforts. And the goal was really to improve perinatal access and to help women have healthier or adapt healthier behaviors, as well as giving support to women and for the pregnancy and in the early childhood years. The program, we know that over the years, we have noticed an improvement in infant mortality rates, which is amazing. But at the same time, we actually saw an increase or worsening of perinatal rates for moms. In fact, over the years, we have noticed an increase. For example, the mortality rate was 17.4 deaths per 100,000 live births in the year of 2018. Well, that rate increased to 23.8 deaths per 100,000 deaths by the time we hit 2020. Very disappointing, even more disappointingly and alarmingly, we know that the rates of Black women were 3 times the rates of Caucasian women. So, this putting this all into perspective, because you're probably wondering, well, where does this fall amongst other nations? To give a little bit more perspective as to why these rates are so alarming, in terms of developed nations, and the nearest nation or the nation with the nearest amount of maternal deaths is France. France is the second highest, has the second highest maternal mortality rate amongst the high income / developed countries. Well, the US maternal mortality rate is 3 times that of France. So, to put things into perspective, the United States is an extreme outlier when it comes to maternal mortality compared to other nations. And in fact, because I've been looking at these stats for years. And in fact, when you look at the stats, you will actually see that developing nations, there are some developing nations, which are considered to be lower income nations, who actually have maternal mortality rates that are better than the US. So that's just to put things into perspective. So one of the things we ought to be very concerned about when it comes to maternal mortality is the access to obstetrical services. Have you ever heard of the term maternity care deserts? Well, this is an important term to be familiar with. Why? Because we know that these counties exist throughout the US. In fact, 36% of counties in the US are designated as maternity care deserts. So you're talking at least 1 in every 3rd county in the US is a maternity care desert. And a lot of these counties exist in the Midwest and in the South. So, what is a maternity care desert? What a maternity care desert is a county that either lacks the access to maternity health care services or have very limited access. These are counties where there is either no obstetrical services or limited obstetrical services provided, or there are barriers that prevent women to be able to access those services. And a lot of these counties are in rural areas. So we're going to talk more about that. But let's talk about just even the closure of obstetrical services in various counties throughout the year. But let's talk about why are obstetrical services becoming more and more scarce throughout the nation. In fact, more than 400 maternity services closed between the years of 2006 and 2020. And this has not stopped because even at the top of last year, between the months of March to June, 11 healthcare systems announced that they were closing their maternity care services. That is an alarming number. And these healthcare systems announced that they were closing these services either due to low birth volumes or a staffing challenge. So let's first tap into what is that staffing challenge? Let's talk about it. So did you know that the United States is currently facing a shortage of obstetricians? Yeah, a lot of people aren't aware of that. So why are we having such a shortage of obstetricians to begin with? In fact, in 2000, and this is not a new issue, in fact, in 2017, the American College of OB-GYN, for those who aren't aware, that is the professional organization for OB-GYNs, the organization that is responsible for our statistics, our guidelines, and also advocacy on a federal basis. So this organization is the go-to organization when it comes to management, what's going on with women's health, what are some of the trends in women's health, and any type of changes in terms of how we care for patients typically will come through the American College of OB-GYN. It is not the only professional organization for women's health, but it is the major one. So according to ACOG, which is the American College of OB-GYN in short, in 2017 announced that half the counties in the United States lacked an OB-GYN. Wow, that number even surprised me. I didn't realize that the shortage was that severe. And in fact, currently we are facing a shortage of over 8,000 OB-GYNs. And the estimate is by the year 2050 that this number will skyrocket up to a shortage of 22,000 OB-GYNs. That's alarming. That means a large percentage of the counties in the US will not have access to an OB-GYN, which is the most trained to deal with higher risk and complicated pregnancies and births. So as a result of the growth of the women who are over age 18 by 33 million, we ended up having an increased need for obstetrical services without an equivalent rise in providers who can care for women. In fact, according to the Association of the American Medical Colleges, the number of OB-GYN positions as residents grew less than 200 between the years of 1992 to 2016. So, there, compared to the rapid growth of women of reproductive age, the training to increase the amount of OB-GYNs have not caught up with that rapid growth. There are a couple of things that are very unique to the career in OB-GYN. And one of the things that's unique to the career in OB-GYN is the fact that we have a higher burnout rate. So you have compared to other specialties, OB-GYN as a specialty ranks number 4 out of 29 in a 2018 report as to one of the specialties with the highest burnout rate. And so some of the efforts has been towards retaining OB-GYNs to continue to work in the field. So there's an increased effort by medical schools and teaching hospitals to improve the retention of OB-GYNs, because a lot of times you will lose OB-GYNs not as we become active in our careers, but even during the training process, which is typically very grueling. There's an encouragement also, or an effort to encourage OB-GYNs to serve in underserved communities like I do. I've worked in community healthcare and I've worked in that area for a number of years now. But I will say there is a unique a unique experience to those of us who work in community healthcare. It is a challenging road. And so that's why oftentimes it's very hard to retain OB-GYNs in this particular sector. I guess I'll share a little bit about my experience in another time. The other thing that efforts have been focused on is just extending the work years of OB-GYNs. So OB-GYNs tend to retire at about 59 years old. And so you have during this time frame also where we are seeing a growth in the demand for reproductive services. We're also seeing retirement of OB-GYNs at the same time. And so, as you can imagine, it will affect those numbers. One of the major causes of early retirement for OB-GYNs has been cited as the legal issues. So, as you know, OB-GYNs or women's health is one of the highest has one of the highest rates of lawsuits. In fact, it is said that at some point in our careers, 2/3 of OB-GYNs will face legal action. It is the highest amongst all specialties, according to a 2018 special report. Over the years, also, with the expansion of science and the growth of different areas within women's health. So, as you know, female pelvic medicine as a subspecialty became a subspecialty recently in recent years. But there have also been growth in other subspecialties. So you have those who go into laparoscopy as a specialty. They continued influx into GYN oncology, those who specialize in maternal fetal medicine, which is our high-risk pregnancy specialists, and those who are specializing in adolescent medicine. So there's a number of subspecialties, which is a reflection of the growth of the science behind these clinical areas. But as a result, you have a decrease in those who are responsible for childbirth and for pregnancy care. So the growth of subspecialties have been another cause for the increasing shortage of those who directly deliver and care for women through the pregnancy and the postpartum period. According to Dr. William Rayburn, who at the time was the associate dean of OB-GYN at the University of New Mexico Health Sciences Center, who also authored the 2017 ACOG report that predicted this particular shortage. According to Dr. Rayburn, he said, because OB-GYNs are among the least compensated of all surgical specialties, an increasing portion of residents pursue fellowship training in high specialized areas where reimbursement is higher. And so he believes that part of the attraction to some of the subspecialties is two things: to have access to a better compensation than being a generalist OB-GYN, but also you have better working hours. As you know, babies come when they want to come, and the lifestyle of a generalist is also considered to be one of the most grueling that leads to the higher burnout rates. And so he believed that those were two major factors why we're seeing a growth in some of our colleagues pursuing these specialized areas. He also mentioned something else that I thought was really interesting. As you remember, at the very top of this discussion, I mentioned that there's a higher rate of maternity care deserts in rural areas. And one of the things that he mentioned that I thought was really interesting was that he believed that because OB-GYNs are highly trained professionals, that we tend to live in more urban areas. And because we tend to be attracted to more urban areas where we can participate in certain aspects of our lifestyle, so cultural activities, which is really important for our mental health, better services, to have access to better services ourselves, and more collaboration with other medical specialists, higher rated schools for children. So in terms of lifestyle and sort of the quality of lifestyle that a lot of OB-GYNs are seeking, Dr. Rayburn also mentioned in this article by the Association of American Medical Colleges, he mentioned that he felt that the lifestyle of living in an urban area would tend to attract more someone who is of a higher professional training. So I thought that was very interesting because he alluded to the fact that the attractive lifestyle and some of the desirable lifestyle in an urban area maybe why we're seeing the shortage in more rural areas. So let's talk more about exactly what this shortage is and what are some of the ways that we are approaching to try to combat these maternity care deserts. Okay, so just to bring some more light to these numbers, because these numbers are really, really important. There was a report that was put out by the March of Dimes, one of our favorite organization that is actively involved in improving the care of women when it comes to maternal care, and also looks at some of the disparities in women's health, trying to improve the care of all women so that all women have access to equal and equitable health care. So according to the March of Dimes, and I should also say their efforts are not just in improving maternal health care, but also improving infant health care as well. According to the March of Dimes report that was published last year in 2022, there were 900 maternal deaths reported in 2020. And when I say maternal deaths, I mean any pregnancy related deaths from conception all the way through the first year of life of the infant. This was noted to be a 14.2% increase from the previous year, and in fact was a 30.9% increase from the year 2018, which was just 2 years prior. So let's talk about these maternity care deserts, because the lack of access or limited access to obstetrical care, as you can imagine, will have a tremendous impact on maternal health care outcomes. So let's go over some of the key findings in this particular report. The report found that more than 146,000 babies were born in maternity care deserts. 146,000 babies, and an additional 300,000 babies were born in counties that had limited maternity care services. So that means more than 2.2 million women of childbearing age live in maternity care deserts, and 4.7 million women live in counties that have limited maternity care deserts. And we're in what year? That's incredible. What's important is how much this impacts certain groups of women. So we know that Medicaid accounts for more than 50% of births in maternity care deserts. So definitely your women who have lower income. So clearly those counties that have lower income and so lower reimbursements compared to private insurance are more highly impacted by the lack of obstetrical services. This is compared to 40.1% in counties with full maternity care access. And what was found by this report also is that women who live in counties with limited or poor obstetrical services access were twice as likely to live below the median household income in the United States. So again, the poor populations of the US. Women who live in areas of maternity care deserts also tend to have certain characteristics or certain medical conditions. So they tend to be more likely asthmatic, they tend to have more hypertension, and they tend to be more likely to be smokers of tobacco. Kind of makes sense, right? So if you're dealing with the more underserved communities who tend to have a lot more social economic strains and pressures, they will tend to be more likely under stress. And I'm not saying that these are findings of this report. These are just kind of my interpretations of the report. So if you have women who live in poverty, as the report identified, and are more likely to live in these limited access areas, they're more likely to have daily stress from socioeconomic issues, and so are more likely. How do people relieve stress? By smoking. Oftentimes smoking is what people choose as a stress reliever. And what happens to the body when it's under chronic stress? Blood pressure tends to be higher. So that's not too surprising. But also in these communities, environmental toxins tend to be higher, right? And so it's not unusual that you'll find that people who live in these communities tend to have more reactive airway issues, and in this particular case, identified as asthma. So these findings are making sense, right? And as I mentioned earlier, 36% of the counties in the United States have been designated as maternity care deserts. In fact, 2 in 3 maternity care deserts are in rural areas, so 61.5%. And that was the number I was alluding to earlier. What was really interesting is over the years, we have designated the postpartum time period as ending abruptly at 6 to 8 weeks postpartum, depending whether you're postpartum vaginal, postpartum C-section, based on the major physiological changes that have then been restored by that time frame. But now we're learning more and more that some of the effects of the postpartum period, such as postpartum mood disorders, can extend much further out. And as a result of that, one of the things that has improved over this time frame is that in 13 states, they have approved legislation to extend the postpartum Medicaid coverage to 12 months. So that is a great benefit because that will increase the services of women to be able to be taken care of adequately in that postpartum time period, because the maternal mortality statistics is not just pregnancy and the delivery time period, but it includes the death of women up until a year. So if we're concerned about the death of women up until a year postpartum, then they ought to be able to have pregnancy related services through that time period. And keep in mind, there are some women who don't have insurance otherwise and can only qualify for what is called emergency medical services based on the fact that they are currently pregnant. So the extension of the Medicaid services is absolutely critical in low income communities. So let's talk about what are some of the things that we have found we probably should be doing a lot more. So we're going to talk about that now because there is hope. We just have to move the system and legislation to catch up with the findings of a number of reports that have looked at maternity healthcare systems. So now that we know what are potential solutions, let's make them happen. Let's activate our federal government and our state governments to take suit on some of these findings, because it doesn't make sense to have these findings and then not do anything about them, right? I think you guys can agree on that. So one of the things that have been noted or cited as a potential way of improving outcomes is what we call these childbirthing centers. So CBCs, or childbirthing centers, have excellent outcomes. We know have excellent outcomes for women who have low risk pregnancy, as cited in a JAMA article that I utilized for some of the information I'm sharing with you today. And I will note the references in the context of this video as well, so that you can go and look at this information for yourself as well. We know that freestanding childbirth centers improve perinatal care, improve labor and delivery outcomes. They are more likely to use midwifery and wellness approach to pregnancy, which is a beautiful thing for women. But you're probably wondering, well, what if someone is more high risk? Well, they tend to partner with hospitals to take care of more complicated outcomes or more complications. So what are some of the outcomes that we're finding with childbirth centers, these freestanding childbirthing centers? Well, here are a couple of things you should know. They are more likely to provide continuous support during labor. And so the labor courses tend to be shorter. They have lower rates of C-sections and vaginal and interventions with vaginal deliveries. Their newborns have higher APGAR scores. APGAR scores are sort of a assessment of the baby at the time of birth. That is an indication of the health and the well-being of the baby. And they tend to have higher patient satisfaction. Sounds like a win to me. The other thing that has been calculated, because as you know, the healthcare system is an extraordinary expense to the American government, but we haven't really been able to show the improvement in healthcare to justify the amount that we spend in healthcare. That's another topic. But relevant to what we're talking about now, it's important to know one analysis found that by using the CBC model, that we can, even if we just improve or increase the use of CBCs by 10%, we can actually reduce the cost or save $10 billion annually. So they have improved outcomes, and we can actually save $10 billion annually by utilizing this model. Again, sounds like a win, but important to know that this model is directed for women who we consider to be low risk. And I will talk about that aspect in a moment. The other thing that is a drive that we're finding is that there are still states that are behind in expanding the utilization of midwives. We know that hospital systems that utilize midwives have better outcomes for both in-home and in hospital births for low risk women as well. And there are two groups of midwives. We have the certified nurse midwife, as you are familiar with, the one that comes on our platform. Olivia, that comes and joins us on our platform. She's an example of a certified nurse midwife. And then you also have certified midwives who are not nurses. And there has been a lag in utilizing CMs as opposed to CNMs in the healthcare system to improve outcomes for women. So many states are behind in recognizing the skill sets of CMs and in utilizing them to improve perinatal outcomes. So it's very disappointing because we know that there is better quality and higher safety in low risk women who utilize CNMs and CMs, right? In fact, one review found that midwifery led continuity models of care were more likely to have fewer interventions. And when we talk about interventions with childbirth, we're talking about epidurals, episiotomies, and instrumentations like forceps and vacuum delivery. They were more likely to have higher patient satisfaction, which is so important. And they were able to have comparable or lower rates of maternal and infant adverse outcome than other care models. So essentially, they work for lower risk women, right? 23 states still do not permit full practice authority to CNMs. The other area where we are behind in improving maternal health care outcomes is in the use of doulas. Doulas, we know, provide great support for women during labor, during the pregnancy portion, during labor, and then after labor, right? So they provide, they're sort of what I consider to be a recreation of the traditional village that in some of our more ancient communities would utilize to support women, not just during the pregnancy and during labor, but even after labor as well. So the doula support has been associated with fewer cesarean sections and fewer interventional vaginal births as well, and also have lower rates of postpartum depression and anxiety. And as we're in a time frame where we're seeing increased rise, especially in anxiety disorders and depression post or as a result of the pandemic, then this is even more critical to expand the use of doula services. Currently, there's only 15 states, the last I checked, that actually reimburse doula services. And then there's still a little bit of a battle as to how much they're being reimbursed for their services. And we know that the utilization of doulas also is more cost effective. So why not improve the reimbursement, expand the utilization of doulas across every state so that every mom has access to doula services so that we can have these improved outcomes that we know exist, especially these outcomes are even more profound in communities of socioeconomic disadvantages. So we know it works. We know the system works. So let's expand the access of doulas. I will tell you as a clinician, I love the support of doulas because there's certain things because of how healthcare is structured. And that's a whole other conversation. There are certain things I don't literally have the time to be able to do because of the volume. And so the utilization of support services like doulas is just so incredible because they're able to do and fill in the gap of things I personally can't do for the health and the support of my women based on how the healthcare system is currently structured. So even those of us who see the importance and value the importance of these types of services and support for women, this healthcare system is currently structured in a way where we can't even provide those services. So until that aspect change, we definitely need and should improve the support of doula services. I also trained with midwives, so I can tell you, I know. You didn't need to give me these stats for me to know. I know how important midwives are to the support of women. I've watched how they support women during labor, how they're able to give that 1-on-1, 2-on-1. Their ratio of care to women is lower in the hospital setting. So they have more time to really spend and give that support to a laboring mom, whereas doctors we're all over the place because there's so many. We have patients in ICUs, we have patients who are laboring on the floor, we have the postpartum patients to deal with, we have the ER to deal with. So just the logistics of being able to give women that incredible support that midwives can just does not happen. And this is why it is not surprising that in the low risk population that midwives are able to have these great outcomes, because I've personally witnessed them doing it, and it's a beautiful, beautiful birth to witness. So that being said, we have layers and layers of things that we should be doing to that we know are solutions. So when you are making decisions for leaderships and people who represent you in the government, make sure they understand and are behind these changes. If we don't get behind moms and support moms to have healthier pregnancies, then what does that say for our priorities in our governments, our priorities in our homes? If we don't improve the support of women even in the home system, so if families aren't even supporting women in the home, if husbands aren't supporting women in the home, how can we expect the government to prioritize it? Because the government is kind of a reflection of who we are to a certain extent. But intentionally, that's the reflection of the government. They are representatives of who we are as constituents. And so it's really important that, one, we echo what we value in our own home lives and in our home systems to improve the outcomes of women, but also echo these values that and principles that we have in the prioritization of women's health and the care for moms by selecting people who represent those belief systems and then holding them accountable to make sure that these changes happen and happen quicker than they have been happening. We know that childbirthing centers work. We know that also, I didn't mention home birth, but home births are in that group. We know that home births, we know that standalone childbirthing centers work. We know that midwives, whether CMs or CNMs, are critical for reducing some of the complication rates and improving patient satisfaction. I mean, how many times now have I heard women share that they feel traumatized by that childbirth experience? So if we have that, doulas and midwives, and they're not the same, everyone. Doulas are support coaches, birthing coaches, and also support systems for pregnancy and the postpartum period. But the midwives are actually the clinicians, those who manage the childbirth, right? And so we are all the best system we can provide for patients is a system where the low risk pregnancies are primarily cared for by midwives and doulas because we know they have great outcomes, and then leave the obstetricians with the increased shortage. If we have an increased shortage of obstetricians, then we can't care for everyone efficiently. So we are to utilize these systems that we know work so that we can focus on patients who really need our advanced training, patients who are a little bit more complicated, who come with more comorbidities to their pregnancies, where we can really focus our advanced training and the science that we understand to care for the patients who are in greater need, decreasing the spread, the thinning out of our care with patients who are better off in other hands, and really focusing our care on patients who truly need that advanced care. This is probably the system that would work for us. And so let's all work together to make this happen. Let's just not throw money in areas that we don't even know work, when we have the science, we have the proof, we have the analyses that show that this is the system that ultimately works. And that's not ignoring the racism and the debunking and removing of the racist thread throughout our healthcare system. That's still acknowledging that, and some of the limited services in communities in terms of reimbursement through Medicaid is a reflection of that. And so this is not at all ignoring that as being the major underlying framework. It's acknowledging that. But now that we have a solution or solutions that could potentially work and have great scientific evidence that they do work, let's get this done for our women. All right. I hope this has added some clarity as to why we're dealing with the circumstances that we are dealing with in healthcare. And I hope that this has improved your understanding and maybe even inspired you to take action and to help us improve our outcomes for women. This again is Dr. T, the hand behind the handle of Healthy Bump. Club on Instagram and Healthy Bump Club here on YouTube. As you enjoy our videos, we encourage you to check out some of our other topics, which are sometimes a little bit related to these topics and can give other aspects of the issues at hand. And also, we want to remind you to, as always, make sure that you do what? Like, share, and comment. That helps us to get ahead in this virtual world and provide the information that you value to those who don't even know that we exist. And so we thank you for watching our videos. We thank you for supporting here on YouTube and on Instagram, and for also sharing and purchasing our apparel line and becoming a visible part of the village. We thank you for doing that. All of our links and all of our critical information is going to be in the context of this video, so you can check it out below. And when you're done there, again, don't forget to check out some of our other episodes if you've missed a few. We talk about a whole lot of stuff, and we talk about these critical topics that are important to our followers. So as you are going through your pregnancy experience or your reproductive years and valuing this information, or you may not be in your reproductive years or do not desire to have children, but value the information we're sharing, and you want to be part of someone's village, we encourage you to do so. And then also we encourage you to be active on the civic aspect, because as you know, a lot of these changes can only happen if our federal government and state governments make these critical changes. So thank you once again for watching, and we hope that you do what? Have an amazing week. And we thank you for hanging out here, and we'll see you on the next episode.